So just a couple of housekeeping items. So firstly, my name is Sonia Khan. In case you haven't seen my face yet, I'm with NCSD, the Senior Manager of Disease Intervention. Hopefully, I'm aiming to have the recording up for this meeting next Wednesday. If you have any accessibility needs that you'd like to request, please directly message Ali. Ali, I'm assigning you this, this item. And you can do that by going to the chat button, which is kind of in your center bar. And you should be able to select Ali directly, Alexandra, from that list. There's going to be a survey that pops up at the end of the meeting. Just a quick 2-question survey. If y'all could fill it out, it helps us improve the content that we bring to you all. And if you're interested in subscribing, if you're not already on the NIPS listserv, please email Ali. Her email address is right here. So today we'll be learning about a little more in detail about congenital syphilis and EMR chart abstraction. We'll be hearing from Hilary Reno, who's the medical director at St. Louis STI and HIV Prevention Training Center. And then we'll be hearing from DSTDP's surveillance folks, Michelle and Kevin O'Callahan. And Hilary, I will turn it over to you in a moment. I did want to get a poll of folks real quick, though, just to kind of get an idea of where we're at. To help us facilitate the conversation today, I'm going to launch a poll. If you all could kind of give us an idea of which best fits your role. So are you a DIS, are you a DIS supervisor, field operations manager of some kind, STD program manager, surveillance staff, clinic staff, or something else? And I see a good number of folks adding other to the poll. If you're willing to share and you'd like to share, feel free to drop that in the chat if you fall under that other category, just to get an idea of who all is in the space with us. Are you all able to see the polls running live, or do I need to share it? What does it look like to you?
I can see it live.
Oh, cool. Yeah, so it looks like a lot of us are DIS here, and a good number of us are DIS supervisors or field operation managers of some kind, some type of DIS manager. Great. Okay, I'm going to go ahead and close this one here. So here's where we're at. So we have a good number of DIS and DIS supervisors, and then other. And again, if you'd like to drop what your other role is in the chat, that would be helpful for us. Another question that I'd like to ask before we get started on this conversation is where we sit with our congenital syphilis investigation. So do you work on maternal or congenital syphilis case investigations, yes or no? So let me see if it lets me do this one here. And if you were all able to join our last NIPS call as well, some of the feedback that we got was that folks wanted to hear a little more about congenital syphilis. So trying to cater our content that we share based on needs. Oh yeah, so it looks like most of us are working some type of maternal or congenital syphilis cases. Great. I'll give another minute for folks to kind of add their answers. Cool. All right, and then the last question I have is, since this conversation will kind of be around EMR chart abstraction as the second part, how many of you all have access to some type of electronic medical records that you or your program area uses, whether that's via someone else on your team or if you directly have access? Okay, so it looks like a lot of us have some type of access to EMRs. Cool. And if anyone would like to share additional thoughts in the chat on accessing, whether it's that person or that EMR, that would also be great for conversation. Cool. I'm going to go ahead and close this poll then. Thank you all. I am going to allow Hilary to take over. Do I need to stop sharing? Maybe let me stop sharing first. And Hilary, go for it.
Hilary, you're
Hilary,
muted.
we can see your screen.
See, there was a problem. I knew there was a problem. You can see my slides. You just can't hear me. So good afternoon. I am going to cover some information on syphilis that really it's important to understanding syphilis, but it's also important to management of syphilis and in pregnancy. And so what I was trying to think of a witty title that just wasn't going to happen. So we're going to go with the, our conclusion at the end of this should be, what's the best time for congenital syphilis prevention? It should be something we can answer by the end of this. So let's kick this off with some must-knows in understanding syphilis. And yes, I usually teach interns and residents and stuff, but this applies to everyone, to all clinicians, including DIS. And I do consider DIS clinicians because you have so much contact, face-to-face contact with patients, as same applies to public health RNs and our traditional sort of providers. But, syphilis is something you have to be aware of before you can diagnose it, right? And so we'll talk about this a little bit in one of the cases, but syphilis it is known as the great masquerader because it causes so many disease presentations similar to other disease presentations that it hides in plain view. And so to have a diagnosis of syphilis, it has to be on your list of what could be causing the patient's symptoms. We also know that T. pallidum, the bacteria that causes syphilis, disseminates at every stage. What does that mean? It means that you may have someone presenting with a chancre, with that painless ulcer of primary syphilis, but we know at that time that T. pallidum is actually present throughout the body and can cause, is present throughout the body and will cause other manifestations of the infection. But understanding that it disseminates at every stage, especially in early syphilis, is really important to understanding why we see and can see, for example, secondary syphilis with ocular manifestations, right? That we understand that T. pallidum isn't just causing the rash, but that T. pallidum has been in the bloodstream, gone to different areas of the body that is manifesting as a rash on the palm and soles. But because it's been in the bloodstream, it can also be already causing symptoms in the eyes or in the neurosystem or in the colon or the liver. So that dissemination is a very important thing in understanding why syphilis does what it does. And then we also need to know that the more syphilis we see, the more unusual presentations we're going to see. I've already mentioned something, right? I've already mentioned that the primary chancre of syphilis is painless. That's not always the case. The more syphilis we see, the more primary syphilis we're seeing, we're hearing stories of the chancre being painful. We're hearing stories of the rash being itchy. We have a case currently where it looks like the syphilitic chancre is actually this big, huge bruise, right? That is a manifestation of potentially what we call malignant syphilis. And so there's all these manifestations that we really think of as rare that we're actually seeing more and more because we have more cases. And this follows, right, that this is one reason we have increased cases of congenital syphilis is because people of childbearing potential are more likely to be exposed to syphilis, acquire syphilis, and then potentially spread syphilis to when they are pregnant. So another thing that I find very important, it's really the tenets of caring for people with syphilis, is that every patient with syphilis needs two things. And I know these seem like neurologic review of symptoms. What's that? That's a clinical assessment of someone's neurologic symptoms. So headache, memory loss, eye, vision problems, hearing problems, numbness and tingling, right? So that's a clinical thing. But what's interesting to me is that how much of an impact disease investigation can have when patients have not had these things performed, right? So with how many times do I get a call from DIS that they have a patient with syphilis who, by the way, is mentioning that their vision is blurry. So it's important for everyone to be aware of these things, that every patient with syphilis needs an assessment of their eyes, their hearing, their neurologic symptoms, their neurologic system. And I don't mean they need testing. They don't need an eye exam. What they need is simply questions, right? We are all asking questions of the people with syphilis that we see. And some of those questions need to focus on this. How's your eyesight doing? How's your hearing? Is anyone saying they're having to yell at you lately to get your attention? We have had, again, patients who have presented and been like, yeah, my mom said that she feels like she's yelling at me nowadays, and they have otic syphilis, right? So it's that kind of that triggering that question that and getting patients to answer that's really important to making sure they get the complete management and care that they need. And then every patient with syphilis needs an assessment of their pregnancy status. This is done differently in different places. It could be as simple as, oh, you don't have a uterus. Great. You're not going to be pregnant. But it also may mean, hey, when, what sort of birth control are you on? When was your last menses? Some clinics will actually do a urine HCG on everyone who could be pregnant if they have syphilis. That's what we generally try to do in the clinic that I'm the medical director of. But we're already assessing the likelihood of that by asking people when their last menstrual period was and what birth control they may or may not be using. So assessment of pregnancy status, absolutely essential for anyone that has syphilis. So this talk is only 15 minutes, so it's really not meant to cover all the clinical manifestations of syphilis, but we really want to concentrate on some important things that are essential to know about managing people who are pregnant with syphilis. And so this is a diagram from a New England Journal of Medicine article written by a couple of our national experts in syphilis, and it really lays out in a visual diagram what happens with infection. So infection with T. pallidum leads to primary infection with that chancre or swollen lymph nodes. And then, like I said, about 40% of the time, as the T. pallidum disseminates, you can have central nervous system invasion. So you can have ocular syphilis with primary syphilis or secondary syphilis, or syphilis, non-primary, non-secondary syphilis with neurologic manifestations. So all of those things can happen in this wide variety of presentations, but this is a really nice, concise visual diagram of that. And what we can do is kind of look at this and group it and note a few things that are really important. First of all, do understand that this is something a lot of people don't realize. If someone is presented with a rash that's resolved, but they were not diagnosed with syphilis, nor were they treated, that can actually recur. So about a fourth of people with untreated secondary syphilis in that early sort of 1 year phase can have recurrent secondary syphilis findings. So that can kind of set off our timelines, but it's important to note. Also, I've already pointed this out a number of times because it's super important that ocular syphilis and otic syphilis can occur at any stage of syphilis, primary, secondary, or down into late neurosyphilis stages. And that this is a slide I left it the way it was. I use it to talk to clinicians about the stages of syphilis and management, but I wanted to point out how important it is that that everybody, our healthcare systems, work with GIS and the health department to review the history of someone's syphilis testing and treatment, because that's absolutely essential to staging somebody. We don't know these time periods if we don't have their past history of RPR tests and of their treatment. And that becomes really, really important when someone with syphilis is pregnant, because we are dealing with a somewhat limited time frame, and getting that history and talking and knowing to reach out to your DIS to get that history is something that everyone who sees pregnant people needs to know and understand. So I just want to show you that this diagram is also useful because as we go through the stages of syphilis, we can also lay over this diagram the management of syphilis, that primary, secondary, that early stage non-primary, non-secondary syphilis would have 1 shot of penicillin for treatment, that 3 shots are used in syphilis of unknown duration or syphilis of late duration, and that tertiary and CNS syphilis, and including ocular and otic managed syphilis, demands 10 to 14 days of IV penicillin. So this being said, and kind of talking about the time frame and how important it is to stage and correctly manage syphilis, ensuring quality care for syphilis, especially for people who are pregnant with syphilis, really requires a team effort, right? It cannot be done by a healthcare system alone. It cannot be done, well, it can actually be done by DIS and the health department alone, but it's certainly better if we have a team working on this. So let's just go through a quick case. And I want to make sure we've got, I've got my time kind of noted. Let me know definitely, Sonia, if I am going too long. But the case that I wanted to talk about was a 24-year-old cisgender woman who's going to see her women's health nurse practitioner for her pap smear, her STI screening. She reports 2 cisgender male sexual partners in the last year. So here's something really important, right? This is obviously a nurse practitioner that is taking a sexual history and is able to assess this patient's partner status, and that she does use condoms occasionally, and she is on birth control pills to prevent pregnancy. But the patient notes she'd like to stop them and is really planning to become pregnant this coming year. So her pap smear returns normal with no abnormality noted, and her gonorrhea and chlamydia testing was negative. So what advice on conception and pregnancy would be true here? A, that she should start a prenatal vitamin after she is pregnant. B, that she has been tested for STIs and will be tested again when she is pregnant. C, she does not have an STI, so her partner or partners should not be tested for STIs. And or D, an STI during pregnancy can cause complications. So which of these statements is true? And you can kind of just think about it in your head. And there is only one correct answer for this. So at least in my opinion. I'll give you a second, but really what everyone's, see some D's in comments, thank you. Yes, so D, STI during pregnancy can cause complications is true. So obviously people start prenatal vitamins before they're pregnant because the goal is to have those vitamins available for early fetal formation. And then B is incorrect because she's not been fully tested for STIs, right? So what do we see in her testing? We see she's had a pap smear and gonorrhea and chlamydia testing, but what she has lacked really is syphilis and HIV testing, not reported here. And she doesn't have an STI. Well, we already established she wasn't fully tested for STIs, but her partners should not be tested for STIs. I think this is part of a conversation that we really need to encourage in the healthcare environment. And that is, as someone plans to become pregnant, we do need to talk about what that means as far as their need potentially to avoid exposure to new STIs, right? So I would contend that D is the correct answer here. And my main point is to point out that she received what we would have considered usual care, right? Aside from the syphilis and HIV screening. And I think that's something we're going to come back to. So when we talk about the prevention of congenital syphilis, there are a few key points that I would bring up. One is that we are really working at a time where many of the clinicians that are practicing now did not train when syphilis was more common. And so syphilis was more common in the 80s and the 90s, and then declined markedly. And I actually remember the first case of syphilis I saw. I was a third-year medical student, and we happened to have a patient present with neurosyphilis. I, by and far, was the exception to that. I had not decided to go into STIs at that point, but The fact that I had experienced and understood neurosyphilis from the beginning, really the beginning of my clinical training is a bit unusual. I meet many physicians now, many nurse practitioners, many PAs, and nurses who have not seen syphilis in their general practice. My primary care doctor, every time I go into his office, recounts how many cases of syphilis he's seen, because up until a year or two ago, he hadn't seen any in a very long time. Now he's seeing it pretty regularly. But the point is that they just don't have experience with syphilis. And so they're not going to have it on their differential. They may miss it. All of these things is obviously going to impact patient diagnosis and care. So what is the role for screening in syphilis? Like who do we think should be screened? When should they be screened? We're going to come back to that, put a pin in it. I'm going to give you another question that I think is going to be pretty obvious of an answer, which is how do we make sure that screening is important in the whole reproductive life timeline? So for anyone who can be pregnant at any point in their upcoming future, how can we make sure that syphilis screening is important there, right? So, Sonia, I think we'll just see the time for me. We might want to save my questions till the end. All right. So with all of this kind of this discussion, let's look at a timeline. Now this would be, I would consider the reproductive timeline, maybe not fully complete, but it does include one pregnancy. Of obviously the timeline should be carried out to include any subsequent pregnancies until the point in which menopause has occurred, right? So here we have, this is from the California Department of Public Health Congenital Syphilis Toolkit. And you have at the beginning a person who can become pregnant who is prior to pregnancy. So syphilis can be acquired prior to pregnancy and not diagnosed or not treated, which when someone becomes pregnant can result in the baby having congenital syphilis, right? So that is one path, one point on the pathway to a baby being born with congenital syphilis. The next point is that syphilis might not be detected or tested for early in pregnancy or treated in time. You can also acquire syphilis during pregnancy that's not detected or treated on time, or you can have treatment failure or treatment being started too late to prevent fetal damage. And so one solution that is proposed to intervene and ensure that these points along the path are interrupted and stopped so that a baby is born without congenital syphilis is that preventing congenital syphilis can be done with screening 3 times during pregnancy. That first prenatal care visit at 28 weeks and at delivery. Now, we all know, based on our jurisdictions, that some places some states have this legislated in, right, to care, where the first prenatal visit, a time in the 3rd trimester, maybe hopefully 28 weeks, because we like that to be a little bit earlier in the 3rd trimester, and at delivery are mandated by state legislation that this screening should occur in pregnancy. But there are a number of states in which that is not the case. I live in St. Louis, in Missouri. Screening is mandated at the first prenatal visit, or whenever someone enters prenatal care. So, and not at 28 weeks or delivery. So there is a variety across the US, but there are some guidelines, including the CDC's STD treatment guidelines, which with its update in 2021 became a little more specific, at least in one aspect of the treatment guideline recommendations. So first of all, the guidelines are to screen all women in early pregnancy. Now, this actually also holds true if you look at screening guidelines from ACOG, and then PSTF has slightly different guidelines. They do talk about the screening in early pregnancy or the first prenatal visit. ACOG and the STI treatment guidelines include these last 2 screening points to screen again twice first in the 3rd trimester, which we recommend at 28 weeks. That way, because treatment needs to begin more than 30 days before delivery, that 28 weeks allows for that. You know, if you're not doing it till 34 weeks, and a baby will be born at 37 weeks and treatment starts at 34 weeks, that's not soon enough, right? So screening at 28 weeks and discovering if someone has been exposed or acquired syphilis at that time gives enough time in general to allow before a full-term delivery at least. And then recommend screening again at delivery with and in communities and populations in which the prevalence of syphilis is high and for women at high risk of infection. What does that mean? So this is where I get a little frustrated, right? Because this requires a heavy carry on the people that are testing and screening for pregnancy in their patients, right? They need to understand what the prevalence of syphilis is in their community, and is that high? If there's anyone here who can tell me if syphilis in the prevalence of syphilis in their community is high with a known definition, I would be very excited to hear that, because we don't define that. It's usually high. People will say, well, it's high if it's higher than the next community over, or if your rate is higher than the state next to you, or if your rate is higher than the national average, right? So, but we don't have a known definition of that, and high is open for interpretation. Also, women at high risk of infection. What does that mean? Well, first of all, we do have a little bit of guidance from what this higher likelihood of coming in contact with syphilis might look like. And that is from both ACOG, STI treatment guidelines, as well as USP STF. And it's things that you would think of. People who are unhoused, who have been incarcerated, who have been in contact with someone who utilizes substances or using substances themselves, for example. So there is some guidance there, but you need to know what that is. And I think that's asking people to carry and to remember these things. It would be lovely if we could simplify that for everyone. And then I will add on to here, my point with that case was to really talk about packaged STI screening. That screening for gonorrhea and chlamydia is indicated in lots of populations. But when we are testing for gonorrhea and chlamydia, we also should be testing for syphilis and HIV in most situations. That packaged STI testing, don't think about just gonorrhea, chlamydia, don't think about just HIV. Think about all those 4 STIs together and perform that testing, because we can treat people for syphilis before they're pregnant. And wouldn't that be a lot easier? So here's another example case that points out some challenges with our management and our how congenital syphilis is occurring. So this is a case where a mom had adequate prenatal care. And the onset of the prenatal care at 8 weeks, she had an RPR, there's non-reactive. She then at 35 weeks with uneventful pregnancy up until that point, present with a vaginal lesion, and HSV testing at that time was negative. No other STI testing was done, and she was treated with valacyclovir. So that's 35 weeks. 2 weeks later, she presented in labor at 37 weeks. No RPR was performed at delivery. The baby was then at 5 months old, noted to have slow weight gain and a developmental delay. Part of that workup looked and did some x-rays of the legs, because if babies aren't moving as expected, then x-rays are often done to see if they have hip dysplasia or something like that. And hip x-rays indicated a periosteal abnormality. So that's the sort of the surface of the bones. And from that is can be pretty characteristic, and congenital syphilis was diagnosed. So I wish I could say this was an old case. It's not. And so this is something that brings up a lot of problems and points out a lot of issues with management of syphilis in pregnancy, right? So this mom had a non-reactive RPR at 8 weeks. She came in at 35 weeks with vaginal lesion. So what was one of the first things I said? You got to have syphilis on your differential to think about it. So if you're not thinking about syphilis, you might assume that those lesions are HSV, and you do testing and then you give treatment for it, even though the testing is negative and you're not testing for any other STI, right? At the time. So you really boxed yourself in this case, right? And then she comes in labor at 37 weeks. And again, no RPR is done. There's been an RPR at the beginning of pregnancy, but nothing since then, right? And then, of course, unfortunately, the baby shows some of these later manifestations of congenital syphilis with bony abnormalities and a developmental delay that might indicate neurosyphilis, right? So there's a number of different gaps in the care for this patient. One thing that I just wanted to point out, because I feel like I always need to show pictures, when we're looking at the primary, the chancre of primary syphilis, and we're remembering that it's usually painless, some of them are visible, some will not be, right? So if someone notices an ulcer on their penis and they might be able to see it, but for someone who is pregnant and they have an internal chancre, they might never notice it at all, right? Completely escapes their notice. This person happened to notice that she had vaginal lesions and did come in for that. Also, we need to understand, right, that rectal lesions, oral chancres, all of those might be missed by a patient entirely. Patients with syphilis are most likely to present with secondary syphilis to clinical care because the rash is noticeable when people have it. An important note. So, and if anybody can figure out why I have advertisement for Carousel on this slide, I'll be very pleased. But so when we talk about this quality of care for congenital syphilis prevention, we're really talking about not just screening. Screening in and of itself isn't enough. People need to have access to this packaged STI testing if they are childbearing potential, which means that, again, gonorrhea and chlamydia are not thought of as separately from syphilis and HIV. That when we counsel pregnant people, we need to include counseling on STI prevention, right? We need to talk about how it's, if someone is going to have a new partner, especially later half of pregnancy, becoming and being exposed and infected with herpes and syphilis at that time can really lead to marked impact on the fetus. And so counseling pregnant people on how to remain healthy, exercising during pregnancy, all of these things needs to include STI prevention in that counseling. And we also need to remember that syphilis can occur in pregnancy, right? This is I wish I could say that I was kidding, but it's very much the case that people forget that pregnant people have sex. And it's very important that we recognize that syphilis and other STIs can be a consequence of that. Thank you, Sonia. I'm going to try to wrap up. So I'm going to say I have Carousel on here because one of the songs in Carousel is You Never Walk Alone. And I think that's another really important point for congenital syphilis prevention, that this is a combination of a lot of efforts in public health. So that it's not one healthcare system's issue, it's everybody's issue. This CDC STI screening guidelines, I've already walked through those and walked through the problems with those and why I think they're not specific enough. I do like that we've moved to 28 weeks gestation as a recommended time for testing with that specificness, but we have a lot of non-specificity in our screening recommendations, and that opens us up to problems. The other issues that we mention in the management of syphilis and pregnancy, one thing I want to make sure is that that we understand that in the management of syphilis, partner services is not the same as prenatal care, right? Prenatal care is what's happening in the office. It involves a lot of different things, but partner services is something very specific and very valuable. And so from the DIS perspective, things like, I always talk about this goal is 7 days between doses of IM bicillin for someone who's pregnant. And if a person misses a dose, it doesn't mean, you know, you have 2 days to get them in. And this needs to be done again as a group effort, right? Everyone's on board to get that person in 2 days. That are just because you can give doses 9 days apart doesn't mean you should. We've really made this recommendation of 7 days between doses of bicillin so that you have 2 days to utilize the resources from your health department, from DIS and from the clinical systems to get people back into care so that they get that shot before the 9 days run out. right? And again, I just want to emphasize that partner services is not the same as prenatal care, that the goals in partner services are going to be different, and that's okay. We can still all work together to make sure that syphilis is treated. All right, so I'm going to wrap up. I'm going to say that I did have some solutions, and I just want to point on this one, which is, what do healthcare providers need to know? Well, they need to know that Bicillin is the best treatment for someone who is pregnant with syphilis. They need to know that it's critical to get patients in so that they're treated. And part of solving that and improving that is increasing the visibility and the awareness of what DIS does. And so I think that's very important in our field in public health, is to make sure that the work that DIS does is very visible and recognized and welcomed in our healthcare systems. And then I would encourage everyone to work with their DIS, but also with your prevention training center. Hi. So people like me and medical directors in the health departments, when you have clinics or systems that are falling short a little bit, to have them intervene and help avert that so that the next case of congenital syphilis doesn't occur. And then we all know this is a really complicated area of medicine. Congenital syphilis is one in which we see so many social factors impacting care, that this is just another reason why we need team management, where everyone is working together, collaborating, involving the community, and always working to address prevention and stigma. And as far as Bicillin shortages go, we finally hit a critical stage in Missouri where now we're reserving Bicillin as much as possible for future people who are pregnant with syphilis. And so this is something that just wanted you to know that we're aware of on the clinical team and Division of STD Prevention. And we're hoping that it improves quickly, because when you have one supplier of Bicillin of a medicine, it makes it very difficult when you're in a shortage, especially when one as critical as Bicillin is there. So I'll hand off back to you guys, and happy to answer questions down the road.
Thanks so much, Hilary. That was so informative. So what we'll do is if it's okay with everyone, if you have questions, please drop them in the Q&A chat. That's to the bottom left of your screen, most likely. And if we can have Michelle and Kevin continue. Let me know if you have issues sharing screen, Michelle.
Okay, Kevin's going to share the screen. And we'll get started. Yeah, so I'm going to touch on more of the, Kevin and I will touch on the surveillance piece of congenital syphilis. We'll just touch briefly on things. Give me a second. So going forward. There we go. So I want to be really clear that there is surveillance case of congenital syphilis and there's a clinical case of congenital syphilis, and both can exist at the same time, but they are not perfectly overlapping. So there are instances when an infant meets the surveillance case definition, but does not meet a clinical case definition. And I'm saying this because it can be really uncomfortable for DIS, where the provider is saying one thing and their surveillance staff are saying another thing, and it's okay, and they don't have to agree 100% of the time. And there are going to be instances too where it's a clinical case, but it does not technically meet the surveillance case definition. That's a lot smaller of this slice of pie, but so I just want to say up front that there are differences between these two, and it's okay if they don't agree. And it's because they have different purposes. For surveillance, we really want a uniform criteria that we use to define the disease, and that it's uniform so that everyone is classifying and counting the cases consistently across all the reporting jurisdictions. Whereas clinical is really a patient-specific decision made by the healthcare providers. And I do want to caution you when you are looking at charts and notes that in the medical chart, there may be the terms confirmed and probable, and they may not mean the same thing as when surveillance is saying a confirmed case of congenital syphilis or a probable case of congenital syphilis. So context really matters for these words. There are several routes that you can take to have a congenital syphilis case. There are 4 different criteria that can be met, and each one individually, if they are met, the infant becomes is a surveillance case of congenital syphilis. So really quickly, these 2, the syphilitic and stillbirth and the maternal criteria of the probable case definition, are based on the syphilis status of the pregnant person or the person who's delivering. And so really for syphilitic stillbirth, it's a fetal death that occurs after 20 weeks gestation, or in which the fetus weighs at least or more than 500 grams, and the mother had untreated or inadequately treated syphilis at delivery. These are the exact words from this case definition that we have. So this is what it is. It has nothing to do with the actual infant other than the weight and the gestation. The other one that meets the for surveillance case definition, it's not forwarding, is the probable case definition per the maternal criteria. I'm not seeing it move forward for me. Here, Kevin, I'll give up control if you can forward it. And so I'll just keep talking while he's trying to forward it. In the maternal criteria for congenital syphilis, the whole point is that the mother or pregnant person has untreated or inadequately treated syphilis at delivery. So talking through all these is a whole nother seminar in and of itself. And we can get into that sometime later. But for the sake of time, we're really going to focus today, or a little more, Kevin's going to delve into the infant criteria. And so that is if it's a confirmed case. So the infant has a positive PCR or immunohistochemistry. Turns out Kevin's power just went out, and that is why he lost the PowerPoint. Let me see what I can do. And so it's much easier with slides. Sorry, everyone. So there sorry, for confirmed cases, there are 3 types of lab. There's PCR, there's immunohistochemistry and other stains, and there's direct detection, like a dark field. And then
So while we're Michelle, I don't know. Oh, I see Kevin came back. Okay, I was like, I don't know if you're free speaking or if you needed slides, but I was going to say if anyone has a question that they would have for Michelle, maybe we could answer that while Kevin's getting his screen back up. If that's okay, Michelle, unless you want to keep talking, if you have your points, whichever is easier.
Yeah. There we go. We're getting somewhere. Let's try again.
I'll say a quick apology. I think I'm in the midst of a thunderstorm right outside Atlanta right now, and I think there was a brief transformer lightning interaction.
No problem. All right. Okay. All right, so this is what we were talking about, going back to the maternal criteria. So it's where the mother had untreated or inadequately treated syphilis at delivery, regardless of signs in the infant. And this is why we could spend a whole session on this completely of exactly what is adequate treatment. But for the sake of time, we are moving on to these, which are the infant criteria. As I mentioned, the confirmed congenital syphilis case is they have a positive or demonstration of T. pallidum by dark field microscopy or PCR or immunohistochemistry or special stains. And the final one is probable congenital syphilis by infant criteria. So an infant or a child who has a reactive non-TREP test, usually an RPR, but could be VDRL. And they have at least one of the following, which is any evidence of congenital syphilis on physical exam, a reactive CSF VDRL, evidence of congenital syphilis on radiographs of long bone x-rays, or in a non-traumatic lumbar puncture, an elevated CSF white blood cell count or protein level without any other cause. So I know I sped through these. I want to make sure Kevin has a bit of time to talk about how to find a lot of these pieces in the medical chart, especially for the infants. Kevin?
Thanks, Michelle. So let me just advance. So thank you everyone for your patience. So I will, it's 2:47. I want to make sure to leave enough time for questions and answers. So what I am going to do is there's probably another, probably another like 20 or so slides to go through. I will probably just gloss over many of them. But I do want to make it clear that all of these slides will be shared. And in addition, these slides are based on a couple of online resources that are available that I think are highly valuable and that I would strongly encourage all of you to take a look at. And so these are hosted on the CSTE, or Council of State and Territorial Epidemiologists page. You can Google CSTE congenital syphilis. It comes up as the first page on the Google search if you put in those 3 words. I think Michelle's going to drop them into the chat as well, the link. But down at the bottom of that page, of the STD resource page at CSTE, you'll find these 2 sections of a CS case classification webinar and a congenital syphilis infant medical chart abstraction webinar, both from November 2020. Both are highly useful. I think they answer a lot of the questions that we get about how to interpret infant medical charts, how to extract the data, how to apply it to the CSTE case definition. So both of those I think are really valuable. If I don't get through all of the slides, everything I was planning on cover was going to be is definitively in there, and I would encourage you to go take a look at it. So let me go. So how do we parse or find the data needed to decide whether a specific infant born with suspected congenital syphilis meets a case definition? And that data is complex, and unlike adult syphilis, where all of it's contained with typically within one medical record, obviously for a case of congenital syphilis, it can be spread across multiple medical records, including maternal or birthing period records, which can include obstetric, prenatal office records, as well as delivery hospital records from a maternal delivery unit of some sort. Whether that's hospital-based or community-based, as well as infant hospital records, including, and this is very true for congenital syphilis, where often infants are born prematurely. It can include a birth hospital, that can be a community hospital, and a secondary or tertiary referral children's hospital if that child is ill and gets referred to a higher level of care. So you can be looking at records that can span really 2, 3, or even 4 different venues, depending on what the healthcare infrastructure for pregnant persons and their children looks like in your jurisdiction. I think these are some key points. Many infants, like I mentioned, with CS are born prematurely. It is one of the specific findings of CS. These miscarriage, stillbirth, and prematurity are complications, direct complications of congenital syphilis. And so infants with CS are often born prematurely, which extends their hospital stay, massively expands the degree of notes that you have to parse through, the degree of results. And so it can really complicate searching for specific data elements within a chart. Like I mentioned, the facility where the infant is diagnosed with CS might be different from the delivery hospital, and that's because many deliveries are going to occur in community or smaller regional hospitals, and an ill or unwell infant with congenital syphilis may get referred to a higher level of care, specifically to a NICU level of care. So having really great relationships with all of the hospitals that are interacting with specific cases in your jurisdiction is important, because you may need to extract data across a number of different institutions and even across a number of different health systems. It was sort of encouraging earlier to see that most people do have electronic access and remote access to at least some of their healthcare systems within their jurisdiction, because I think that is really helpful when you're seeking to extract data related to a CS case. So I will give you the 3 or 4 minute overview of this, and then I think we should really go to some questions, but I want to make sure that we do cover that. Just for background, I am a pediatrician and I'm a pediatric infectious disease subspecialist. And my background is about 5 or 6 years in NICU level pediatric care, as well as about 5 years in pediatric infectious disease care. So I've spent a lot of time writing the notes and writing the types of notes that you're all going to be looking at. So I'm always happy to answer questions, and we will certainly share for Michelle and I our contact details from the surveillance branch of our availability to help you parse some of this data. I think for infant chart abstraction, the important thing is to note is that not all of the data you're looking for is going to be in one place. And that is really because the infant, the maternal and infant criteria, but specifically the infant probable criteria for CS, require multiple different data elements that are spread widely across the medical chart. Unlike, for example, the maternal criteria, where really all that's needed, as Michelle covered, is a pregnant person who has untreated or inadequately treated syphilis during pregnancy, which really just requires evidence of the positive test and the lack of treatment, or evidence of the inadequate treatment. For infant criteria, you're looking for a broad spectrum of infant clinical findings in addition to infant testing. And so it really does require you to look in a lot more places in an infant chart, including really parsing, the pros of a specific clinical provider that, may include a history and physical exam, or what in newborn medicine we would call, a birth history, or a birth or admission note, a discharge summary at the end of their stay, and then daily progress notes. You're also going to need to look at results sections that can cover, infectious disease laboratory, or sometimes immunology laboratory, CSF studies, chemistries, and radiology. The healthcare provider note, most healthcare providers are going to write a note, as you've probably seen, in what's called a SOAP format, which means subjective objective assessment of plan. Subjective updates are kind of, in a progress note, would be, what has happened in the last 24 hours. An objective update would be objective findings, meaning specific measured findings, lab data, imaging results, vital signs over that period. There will be a physical exam. There will be a clinician assessment, which is really the most sort of prosaic of the data elements. It's really the clinician describing what they think is going on with this patient that day, and what their sort of summation of the theory and in front of them is. And then a plan, which is, what are the specific things I'm going to do today for this patient, whether it's providing medication, ordering some lab or imaging studies, planning for discharge, etc. And then physical exam, we mentioned, is in the middle of this, is a specific element that's going to be highly structured, usually in this format, looking at specific organ system findings. This is going to be a really rich place for you to look for the specific findings that are in the infant clinical criteria that Michelle mentioned. So this is, you'll find this flow chart on the back of the 73-126, the CS case reporting form. It really walks you through how to apply infant and child criteria to report a case of congenital syphilis. And it really applies the confirmed case criteria, which is like the positive testing, and then the infant and maternal probable criteria, which really look at maternal treatment here, and then infant clinical findings over here. I'm recognizing it's 2:55. I do want to give some time for some questions, so I will apologize for flashing through these slides, but these slides will be shared. So this really is a walkthrough of the different elements of the infant confirmed and probable criteria and where you might find them in an infant clinical chart. So dark field special stains PCR, for example, for a confirmed case with a description of where those might be found, and then infant treponema testing, the infant clinical findings, which are laid out in the CSTE case definition and where those might be found on the chart. I encourage you to look through this slide deck, which will be shared, but also this is a sort of an extracted version of the bigger webinar that's available on CSTE website, which by the way is recorded and has overlaid narrative from one of our prior DSTDP colleagues and Kimball. It's really excellent. I highly encourage you to watch it. It's about an hour. So obviously what I'm trying to do today is a much condensed version of that, but it definitely will really clearly describe what the chart abstraction process looks like. And then I will jump right to the end and say that Michelle and I work sort of hand in hand with each other as epidemiologists and clinical providers and surveillance resources. We have a case-based surveillance mailbox within DSTDP and within our case-based surveillance team. So for any and all questions related to how you report and notify cases, how you interpret the CSTE case definition, how you apply individual findings in the medical chart, and I'm certainly also available, as a clinician to help you sort of understand and parse some of the clinical findings that you may be interpreting from medical charts, and help you interpret them in the context of the CSTE case definition. So I would say any and all questions that you have related to how to apply the case definition and how to interpret and parse medical record findings, you can certainly always email us and we're happy to help you with anything. I will turn it back over just so that we can get to questions, because I would love to hear any and all specific questions that anyone has related to this topic.
Thank you so much, Kevin and Michelle. Let me remove the spotlight here. Thank you, everyone. Okay, cool. So I want to give folks, so there's some questions here in the chat, but I think maybe if we do not get to your question, I do want to preface it with, please enter it into the chat, because I can either the chat or the Q&A, and I can capture those and I can make sure to send them to the appropriate speaker to pass along and get that information to you if we don't get to it. But I did want to highlight a couple questions. Let's see. And Ali, if you want to jump in, if you see something that's pressing within the chat or in the Q&A, please feel free to jump in. I see one question that might be of interest to some folks. Someone says, can you please provide an example of a clinical CS case that doesn't meet the surveillance CS case definition?
Yeah, these are really rare and few between. It might be an instance where there was no, like the mother had adequate treatment, so the maternal criteria is not met. And it could be something as simple as the infant had signs or symptoms, but no RPR was drawn. Or so, because that is a critical piece of that. Usually it has to do more with missing information. Hopefully you can follow up and get additional labs from the infant. That's not always possible when they are lost to follow up. So in that case where the infant has no RPR, like it's non-reactive, but they have signs or symptoms, technically that does not meet the surveillance case definition. But because of the signs and symptoms, I assume the clinical staff would call that a congenital syphilis case. And sometimes this happens too in adoption cases where not much or anything is known about the birth parent. And so that piece may be missing too. So it's fully reliant on what's going on with the infant.
Thanks so much, Michelle. I do want to be mindful of our time. I want to thank again, Michelle, Kevin, and Hilary for their time. If you could please complete the survey that's going to pop up once you exit, that would be helpful. If you have other questions, I know that there are several that we didn't get to. I'm going to capture these, and what I can do is I can send out kind of like these were some questions that were asked, and kind of get the responses out to everyone if you were registered for the webinar. I'm going to share our contact information here really quickly. Questions that I can pass along to our guests, please feel free to email me directly. And we look forward to seeing you at our next call. Thank you all so much. And